Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by Abbvie, Apellis, Beacon Therapeutics, Janssen, MeriaGTx, Novartis, and Roche. Thank you for watching. We hope you enjoyed this webinar and share your thoughts with us in the comment section below.
Dr. Hurley is a vitreoretinal surgeon at the Ottawa Hospital, and he's also an assistant professor at the University of Ottawa Eye Institute. And he's a great friend to FBC, and we're really excited to have you back to chat today. Hi, Dr. Hurley.
Hello, thanks so much. Always enjoy these opportunities to talk and discuss some of the things we do to help treat people with vision loss. So it's a real honor to be here again, and it's such a lovely time always to chat with you.
So why don't we get started and just sort of set the stage? So can you tell us what is anti-VEGF treatment and what conditions do you use it to treat?
Yeah, sure. So anti-VEGF therapy, of course, has been an evolution, I would say, in therapy of eye disease. You know, we talk about revolutionary change, but when VEGF therapy came along and our ability to suppress VEGF, it really took us forward leaps and bounds in our ability to care for eye disease. So the story of the molecule VEGF, which stands for vascular endothelial growth factor. We've known about this cytokine, that's the special name we give to this type of molecule that exists in the body, and it plays a very important role when we're a fetus developing. It sends signals to grow and develop new blood vessels and organs that are developing, and it plays a significant role, for example, in the GI tract and the cardiovascular system for maintaining healthy blood vessels. So it's an important molecule that's part of our body's makeup. What people found many years ago was when tumors or cancers were growing, those cancers needed to grow new blood vessels so the tumor could continue to grow. And so there was a cancer theory that if you could suppress the new blood vessels, you could stop and suppress the tumor, and eventually it would involute and disappear. And so VEGF therapy began to be used as a treatment against cancer. So things that turned off VEGF were actually part of the chemotherapy for cancer. And then some brilliant observations were made where they paralleled those new blood vessels to new blood vessels that appear in the eye for significant eye disease, for macular degeneration, the wet form, for diabetic retinopathy, for vein occlusions, for artery occlusions. Part of the severe damage in the eye results from new abnormal blood vessels being formed. And there was this sudden moment of epiphany where people realized that, hey, those chemotherapies we're using for cancer that turn off these new blood vessels, we can use them in the eye, and they can stop these new blood vessels and return the eye to a more normal state in some of these very severe diseases. And so initial work was done by giving the therapy by intravenous, okay? And so it went everywhere in the body but got to the eye, and it worked well. But of course, then you got the systemic side effects from intravenous therapy. And so there was some brilliant work down in the States where they discovered at the Bascom Palmer Eye Institute that you could put the medicine right into the eye, and it was extremely effective. So it could take wet macular degeneration and melt it away. It could take advanced diabetic retinopathy and melt it away. And so that was the birth of this whole new line of therapy for eye disease called anti-VEGF therapy. And since its first use with a medication called Avastin, we've seen it go through numerous iterations: Macugen, Lucentis, Eylea, Beovu, faricimab. So we constantly are getting new, more powerful, if you will, or agents that are able to suppress VEGF in different ways and for longer periods of time, so we can turn off this harmful molecule in the eye and actually treat, restore, and maybe not cure, but certainly control some very serious eye diseases.
And as you mentioned, this was a pretty revolutionary treatment. So prior to anti-VEGF, how were these conditions treated and what was sort of their success rate?
Yeah, so the basic hallmark of therapy for eye disease that was associated with abnormal vasculature, so these undesirable blood vessels, was to use a laser to try to destroy them. And we'd been doing that for many years for diabetic retinopathy, and we'd been doing that in macular degeneration as well. But if you think about it, inherently, when you use a laser to destroy something, you damage the tissue around it. So the retina was suffering. We were sacrificing some retina in order to suppress blood vessels and allow other parts of the retina to work, particularly in macular degeneration, where when the normal type of laser was applied to the macula, it could burn away the abnormal blood vessels, but it completely destroyed the overlying retina. So it sort of stopped it from getting worse, but it didn't restore any vision. So we tried various iterations, cold laser, photodynamic therapy, different ways of trying to use the laser to suppress the blood vessels, but yet protect the overlying retina. And none of those were overly satisfactory. In general, patients continued to lose vision. At the best, all we could do was slow it down. So we were really looking for a therapy that could actually bring back vision that was lost.
Yeah, it's interesting how, drastically it's sort of changed the standard of care for patients, and it's really a fantastic
It's
treatment.
amazing. I mean, before VEGF therapy, we got the occasional, we call home run. Wow, somebody's vision actually got better. But most cases, we were slowing vision loss. And of course, when a patient came to see us and they say, I can no longer drive, or I can't recognize my grandkids anymore, I can't read, I can't do all these things I want to do in life. And we're like, okay, well, we'll try to slow down how fast it continues to degenerate. But finally, we were able to give patients medicines that actually restored, improved, enhanced vision. And so that to us takes it beyond a revolution. It was just evolutionary. And the whole thought too that we could inject medicines into the eye. When we first started doing it, we would do it in the operating room. We were worried about risks, and now we understand how safe a procedure it is.
And that's also sort of the basis for other treatments as well that are coming as well through research.
Absolutely. Like we are continuing to push the barriers here and try to get medicines that last longer, that work on different mechanisms, that maybe suppress other molecules that play a role in this condition. Some of the very exciting stuff that we're doing. I mean, one of the big problems is, of course, the medicines wear off. So you have to continuously redose the patient with the medication, and that can be as frequently as every month. Luckily, we're able to spread things out, and some of the newer medications that are being developed certainly have that potential to last much longer. But exciting things are also being looked at, ways where we can give uh, give a DNA sequence to the eye. We can load it on a sterile virus. We can have it get incorporated into the genetics of the eye. So the eye itself can now become a factory to produce the anti-VEGF molecule and suppress VEGF on its own, potentially with one injection. We are working on ways to have the VEGF medication released very slowly into the eye through depots and long delivery systems. And so we're trying to make it just easier on everybody, on the patients so they don't have to come in as much, on the physicians so their clinics aren't so busy, and on the healthcare system so the costs can be reduced.
Absolutely. So I want to talk a little bit more about how those dosing and like the intervals are determined in a minute. But, we often get through our health information lots of questions about the actual treatment itself, because when you first say to a patient, we're going to do injections in your eye, I think a lot of people have a bit of a like, ooh, that doesn't sound like a fun experience. So can you talk a little bit about, what could people expect, before, during, and after their treatment? People ask me like, does it hurt? What kind of questions do you get? And can you walk us through the patient's sort of journey, if you will?
Yeah, for sure. When a patient comes in, depending if it's a first visit or a follow-up visit, the first time you come in for the diagnosis and discuss treatment plans, of course, you'll go through a battery of testing. So we now have imaging modalities that are incredible to give us super high resolution cross-sectional images of the back of the eye to define where the blood vessels are, how severe they are, how much blood and fluid is associated with them. So those tests are done initially, and then a simpler version of the test is done with each follow-up visit to really quantify how the patient is responding to the therapy. During the visits, we also measure the vision. We check the pressure of the eye, the so-called vital signs of the eye, and then we examine the eye to make sure there's not something else going on. And then the injection procedure itself is remarkably straightforward and refined today. Recently, like I'll tell you honestly, recently we had my son, my daughter come for their grade 9 bring your kid to work day, and they were watching these injections and seeing us do them, patient after patient after patient, and they would thought this was going to be the most exciting thing in the world. But honestly, after a few dozen people, my son, true story, he looked at me and he goes, Dad, Dad, don't get me wrong, Dad. Don't get me wrong. Your job, I'm not trying to say it's boring, but it's very, very repetitive. He says, everybody comes into your room, you lean the chair back, you put a needle in the eye, and they leave. And he thought there'd be screaming in agony or something exciting happening. But it's a very routine, standard, safe, straightforward procedure now. So typically, we'll recline the patient in the chair just to make it ergonomically a little bit easier to deliver the medication. And we put lots of freezing in the eye. Typically, that's just drops that numb and freeze the surface, but some physicians will use something a bit more aggressive with a gel, or they might apply a little bit of local anesthetic directly onto the surface with another needle. And so once the surface of the eye is really well frozen, we put an antiseptic on the eye, because we're always thinking about infection. Any needle that goes in anywhere in the human body, of course, that can be a side effect. So we sterilize the surface of the eye. Then once that's done, we mark the location we want to inject. So you might feel a tiny bit of pressure on your eye, and then the needle goes in. And many patients are wondering, well, when it's going to happen before it's over. So each person is different, of course, and each person will experience the injection a little bit different. But most people, they don't find it much worse than pushing on your own skin. Once the injection is done, we sit the patient up. They may check to make sure, the vision is still good and the pressure hasn't gone up in the eye or something like that. And the patient leaves, and you can resume your normal everyday activities. You have to watch out for something like a red eye or a painful eye that might develop afterwards. But even in most cases where the eye turns red, it's just a small little bruise on the surface of the eye. On the eye, it looks brighter red than it would in your skin, but even those things are very minor. And then we plan to follow the patient up at the next appropriate interval based on the testing.
And are there any risks to getting the treatment? Is there anyone who wouldn't necessarily be eligible to get the treatment?
Yeah, that's a great question. And so sometimes we think about women that could be pregnant, for example. So we'll have young diabetic patients or young patients with other eye disease that might need the therapy. We're always very aware of potential complications to a developing fetus, because remember at the start, we're talking about how the molecule and other organ systems plays a very important role for organogenesis, for developing your organs. And so we think about that in women of childbearing age, and want to make sure that we're not injecting somebody who's pregnant or potentially somebody also who might be breastfeeding. In those cases, we think of other medications like steroids, anti-inflammatory. So there's some other bridging medicines that we can use. They have their own side effect profile, but certainly are very safe. But the main risk is infection. For sure, that's the number one thing. It's always on our mind. So we do this in a very sterile condition. I think wearing masks today, we're all wearing masks now still in clinics. I think that's protective, because, our oral cavity, our mouth is potentially a source of infection. So we have it covered now, which is great. We often will use a little instrument that holds the eyelids open to keep any dirt or debris on the eyelids away from the surface. And like we say, we apply that antiseptic to keep it clean. But we always think about that. And that's the one real risk that I worry about in my patients. It's treatable, but now we have to put more antibiotic inside the eye to fight off an infection afterwards. Other things that can happen are inflammation. So apparently you can have a sterile reaction. So it's not infected, but just for some reason the patient reacts to the molecule with an immune response. So the eye gets red and painful as well. Now, other rare risks would be if the procedure somehow doesn't go well. Say the needle is injected too far forward, you could strike the lens and cause a cataract. But many patients have already had their cataract surgery, and the artificial lens that's in there can withstand the needle, no problem. You can also inject in a wrong location and hit the ciliary body, which is a very vascular plane that can cause bleeding inside the eye. And if you go too far back, you can put the needle through the retina and cause a hole or a tear in the retina and potentially a retinal detachment. So that's why you have to be very precise when you do the injection, but under those circumstances where it's appropriately and cautiously done, it's a very safe procedure.
And then this procedure can it be done by any eye doctor, or is it just ophthalmologists, specially trained ophthalmologists? Like, who's doing this procedure?
Yeah, that's another excellent question. So it definitely is considered a medical procedure. So you need a medical doctor to perform that. And you need a medical doctor who's trained in the diagnosis, recognition, and treatment of eye disease. So that implies then an ophthalmologist. So right now, the procedure is only performed by an ophthalmologist, somebody who's done medical school, to be fully abreast on medications and complications. And then another 5 years of purely studying the eye, so they really know the anatomy, they know how to handle complications. So right now it's injected by an ophthalmologist. It could also be an ophthalmologist in training under the supervision of a more senior ophthalmologist. So I do have senior medical residents and fellows. So senior medical resident is somebody who's almost an ophthalmologist. A fellow is somebody who is an ophthalmologist, but now doing subspecialty training in retina. So they'll often inject as well. And then you have retina specialists. So this is what I had the opportunity to do 2 more years of training after I became an ophthalmologist. So I focused just on eye disease. So in many centers, it is a retina specialist who does the injection. But of course, there are not enough retina specialists in all centers. And therefore, there are certainly extremely good ophthalmologists out there who really understand the disease mechanisms, when to treat, when not to treat, and how to safely perform the injection. So it's typically done by an ophthalmologist, a retina specialist, definitely, and occasionally an ophthalmologist near the end of their training.
So another question I had, and this was, I think, a question that comes up multiple times in the emails I've already had from people talking about, you've already touched on this, sort of the duration between the injections. So can you talk a little bit about, how that duration is determined? Because sometimes it's a little bit longer, sometimes it's a little bit shorter. How is that decided on?
Yeah, so the interval for the next injection is very important. So when the original studies were done, they weren't quite sure how to dose this medicine. And so some of the lab work sort of showed that, well, its peak efficiency happens within the first month, and then the effectiveness wears off after a month. And so the original studies were all done with patients receiving the injection every month for 2 years. So you can imagine that's a huge burden of treatment on the patient, on the family who has to take them there, on the doctors, on the clinics, on the testing, everything. And so we quite quickly, within the use of this medication, very interestingly found that each patient is unique. Each patient is different. And in each patient, the medicine lasts for a little bit longer, a little bit shorter period of time. Depends on a lot of factors. Like in diabetes, it might depend on how well the blood sugar is controlled, how well the blood pressure is controlled, concurrent disease of the kidneys or other things. In neovascular macular degeneration or wet AMD, it may depend on how big a load of the VEGF is there, how large the choroidal neovascular membrane or the abnormal blood vessel was. So it's a patient-specific treatment interval. So we'll start at monthly injections. So for sure, I give the dose and I want to see the patient back usually 1 month later, see how well they did. And if we have dried up the retina, if we have melted away the abnormal blood vessels and there's no blood or fluid left, I will start to extend right away. So at the second injection, they come in and they're dry. Well then, let's do the next one 6 weeks later instead of a month later. So I know it lasts in that patient at least a month, but I don't know if it's going to stop working in 5 weeks or 6 weeks or 7 weeks. So we pretty much in Canada step out by 2 weeks to the 6 week period. We check them in 6 weeks. If it's good then we know in that patient it lasts at least 6 weeks. So we'll step it out to 8 weeks. If they come back at 8 weeks and there's some fluid just starting to come back, we know, okay, that patient right now has a treatment interval between 6 and 7 weeks. 6 and 8 weeks. So we'll probably go at 7 weeks for the following injection to make sure they stay dry. And after they've been dry for a period of time, say in 7 weeks, we start to try to push them out again, to see if we've suppressed the underlying disease enough that we can space it out. And by spacing it out, it just makes it so much easier on everybody involved, and it decreases the amount of time people have to spend in the hospital, which I always find patients love. Now, occasionally, you'll be stable at a certain interval, but something happens. A diabetic patient may become sick with some other condition, and that makes it more difficult to control their blood sugars, and they're running a bit higher. And so there's more VEGF driving the disease. And so they'll come in and they've been stable at, maybe every 2 or every 3 month injections, but suddenly there'll be a bit of fluid and we have to shorten the interval sometimes. And sometimes we don't understand why, the patient needs a little bit more medication at this time. Is it their blood pressure going up that plays a role in macular degeneration or something like that? And sometimes no good reason, they're active a little bit more, they need their injections a little bit more frequently. But our goal is always to try to minimize the disruptiveness of this treatment on the patient's lives.
So you mentioned earlier on that there's several sort of drugs for anti-VEGF that are available. I think you mentioned Avastin and some of the others. So can you tell us a little bit about these different medications, how they're same, different, and then how you determine which medication to give to a patient?
So the original anti-VEGF therapy was Avastin. That's the actual cancer drug that's used. It's a larger molecule. It was not designed to be used inside the eye, but it certainly works well inside the eye. It's not manufactured in syringes, which are designed for eye injection. So it comes in a larger vial where it's designed for intravenous application. Of course, we just need a tiny portion of that big vial. So in order to make it very cost effective, we'll take the larger vial that sells for $1,000. We'll break it down to a whole bunch of different doses and then give those to each individual patients in a very cost-effective manner. But studies have shown that Avastin is the first generation anti-VEGF, but again, not designed to be used in the eye. It could provoke an immune response. It may get washed out of the eye more quickly, different things like that. And it is an effective therapy, but thankfully we have many other choices. Lucentis, well, Macugen was the next one that came along on the market, but Macugen, it was only blocking one VEGF molecule. It turns out there's a few subtypes of VEGF molecules. And so if you block all of them and not just one of them, they work better. So after that, Lucentis came out, and Lucentis blocked all of the VEGF molecules, so it worked better. So, of course, it became the drug of choice. Then we had Eylea. That was an exciting advancement. It's a little bit different design molecule, and in its studies, it was given every 2 months instead of every 1 month. And so it became very popular to see if we could spread intervals out with Eylea. Turns out, both are very effective and work well. And now we're getting sort of the next generation of anti-VEGF molecules. We had brolucizumab released, and here's where you have to really make sure you study the molecule well, because unexpectedly, it was almost too powerful. It could dry the retina like no other drug could, but it was probably super therapeutic in some patients and caused some significant inflammation. And so it's really sort of fallen off a little bit in terms of its usage. It's fallen off a lot. Faricimab as a new one, Beoviz, that has come to us. Sorry, Beovu, I said that wrong. So these newer drugs have come out, and they offer the advantage of lasting perhaps a little bit longer, drying the retina perhaps a little bit more effectively. And so we constantly are trying to push the limits. Eylea itself is being reformulated now in a higher concentration, 4 times the dose, and still that tiny safe volume to go inside the eye. So by giving a little bit extra of the medicine, you can perhaps dry the retina more and get that longer duration of effect. And so we're getting more and more choice in the field these days, which is good because some patients respond a little bit better to one and some to another one. And so the more choice we have, the better I think it is. And I think I misspoke with the name. So faricimab is Vabysmo, and brolucizumab is Beovu, or what's also known as Beautiful Vision.
I think it sounds really positive that there's so many choice, because like, as you were saying with the intervals, it's a bit of an experimentation, right? To see what's going to work best for each patient. So the more options you have, the more likely you're to find something that's going to work really well for a person.
Absolutely, because we're in the era of individualized, personalized treatments. We see that in cancer therapy and rheumatological conditions. And so the more specific we can be for that patient, finding the best molecule for that patient and the best treatment interval, the better we can manage each individual in front of us.
So on that same theme, we're also now seeing something called biosimilars coming to market. And I wondered if you could talk a little bit about what are biosimilars and how that might be changing the way that these conditions are treated.
Yeah, and so I actually alluded to one of them earlier when I said Beoviz, because it's so similar to Beovu, but it's actually a biosimilar of Lucentis. So biosimilars are coming out. To understand what a biosimilar is, we have to understand what a biologic is. And so most of us are used to to drugs that are manufactured by taking certain components of the drugs, we add them together, and we produce a drug like aspirin or Tylenol or an antibiotic. And so they're manufactured by taking the atoms that constitute the molecule, putting them together, creating the molecule. I make the analogy to it's like building a little plane out of Lego. You take the certain Lego pieces of a certain color and a certain size, you put them together, you've got the little plane, then you make another one. It's exactly the same, exactly the same, exactly the same. Straightforward, follow the recipe, you get it. So those are the traditional drugs. And those kinds of drugs, they have generics, which are versions of the drugs that are produced once a medication loses its patent, and now other manufacturers can produce it who didn't have to spend a huge amount of money doing the research and development, and thus can sell it at a cheaper price, and we now can drive the cost of medications down. The molecules, the drugs we've been talking about, Lucentis, Eylea, Avastin, they are not those simple kinds of drugs. We call them biologics because they're so complex that's impossible for somebody to just put the pieces together and build them. They have to be grown. So I make the analogy, it's like a rose. You have to put it in the ground, you have to put the seed, you have to water it, you have to give it sunlight, you have to give it the nutrients, and then a rose will be grown. And we can see it's a rose, and we can recognize it's a rose, and the next rose that's produced, and the next rose that's produced, they all look pretty much similar, but they all grow maybe in a little bit different conditions, so they might be slightly different, but we can recognize them. They're all roses. But a rose is much more expensive than a little piece of chip of Lego. So you can see that to produce biologics is a more complicated process, and they're expensive. So many of these drugs we've been talking about, they're well over $1,000 up to $2,000 per dose. So now biosimilars come along, and biosimilars are like a generic for a simple drug. Okay, so now another company has the formula to grow a rose again. And so again, it's this complicated process of manufacturing. The temperature has to be controlled, the environment has to be controlled. A lot of these are grown within living cells, the same way we get insulin. It's grown by human cells. It's not put together. And so we've been using biologics for a long time, but now we understand how complex they are and how the process of making them can vary slightly. So one dose of Lucentis I get maybe a tiny bit different than another dose I get maybe manufactured at a different time. They're going to be similar, they're going to look the same, but if we really analyze them, just like you look at two roses under a microscope, there might be subtle differences between them. So because of this complex nature of these large molecules, the companies that are now trying to produce them at a cheaper price are developing these processes to manufacture a medication which is highly, highly similar, but not identical to the original biologic product. And these are now available in markets here in Canada and around the world. And they're produced so that the cost will come down. Also, they're produced so that it continues to stimulate innovation, and it'll constantly challenge the other manufacturers to come up with the next newer version for which they have a patent again, for which can't be copied for a period of time. So it's always in this spirit of let's produce the next best thing, and let's be more efficient and cost effective, perhaps. That's driven us towards now having these choices available in medicine to complement the original drugs.
So just more choices sort of in your arsenal as you're treating patients.
Yeah, more choices and different price points.
Yeah. So you've alluded to a few of these treatments already, but sort of in the anti-VEGF space, I think you mentioned ones that you're trying to extend the interval, maybe some different systems where the eye is producing its own anti-VEGF. Can you talk about some of the sort of new research into drugs or delivery systems that are being investigated?
Yeah, I mean, I certainly think that concept of taking a retrovirus. So we've seen it in genetic eye diseases. So a child, for example, is born and they're defective a gene inside their eye, and as a result, their retina doesn't develop or isn't developing properly. We now have a way to take the missing genetic information, splice it into a virus, inject that into the eye, and thereby give the cells in the eye the necessary genetic material it needs to properly grow and develop. So that same concept has been applied now to anti-VEGF therapy, where we can now dose into the eye the genetic coding needed for the eye to produce a medicine like Lucentis or Eylea or one of the other anti-VEGF therapies. So in a way, the eye becomes its own factory to produce this at the right quantity, amount, and sustain it. And so theoretically, you give one dose and you turn on that whole genetic system. And if it works, you may have suppressed VEGF in the eye now for the rest of the lifetime of that eye. So that's very exciting. Research had been done for quite a long time on how can we deposit the VEGF medicine in the eye, but have it last a long time. So little microspheres were developed. We have a medicine, Ozurdex, for example, that contains a steroid that comes in as a pellet and slowly degrades to water over months and months, and so slowly releases the medicine. We tried for the human eye, putting these little containers basically in the sclera, in the weight part of the eye, that have a port that goes right into the eye that can slowly release the medicine. And you may only have to refill that once a year, once every 2 years, and the medication will leach out slowly over that whole period of many, many months. So you don't have to come back and constantly get the repeat injections. All of these therapies are still trying to be perfected. And so we don't have something right now to give to the patient that says, okay, here's your injection, it's going to last 6 months. But of course, the goal is to have something that's, effectively a one-time dose, and you've turned on anti-VEGF production for the rest of their life. I mean, now we're talking about curing these diseases and not just controlling them.
And then sort of outside of anti-VEGF treatments, are there other things that are being researched for, AMD, DR that, is outside of the anti-VEGF space?
Yeah, I mean, for sure. We get to the point, sadly, in some patients, they either present kind of late when there's a lot of scar tissue that's built up inside the retina, or sometimes patients become very sick with other conditions and can't get to us if they're in the ICU or something for a period of time. They come back and the disease has progressed to more scarring, and so patients, sadly, some of them have lost their vision, and it can't be restored due to secondary changes at the level of the retina. And so there, we're always turning towards new and exciting options. Can we transplant the damaged tissue? Can we use stem cells, these multi-potential cells that help the body grow and develop initially, to be placed into the eye in order to grow new and healthy tissue to replace the older tissue? Can we put something in that's synthetic? Can we put like an array of microchips that will go over the area of the retina that's damaged and now send the signal to the brain like a TV camera would? And so there's all of these exciting potential therapeutic options for macular degeneration. None of them are going to be here in the coming months, and that's for sure. So short term, we're trying to perfect our current medical therapy until in the long term, we come up with the next evolution in therapy, which will be something, perhaps what we're talking about, or something we still don't understand even today, that might lead to a very, very long-term control or cure of these types of eye diseases.
Well, thank you, Dr. Hurley. Those were all of my questions. So I think we're going to move to some of our audience questions. I see them popping up in the corner of my eye here. So just to remind you again, we're going to tackle some audience questions now. So you can put them in that Q&A box. I see some people have put them in the chat, or you can always email us at education@fightingblindness.ca. So let me open them up here. Let's see here. So someone here, Lucy's asking, she said, I've heard some people telling me that the anti-VEGF has been stopped by the doctor and the disease is not coming back. Is that possible?
Yeah, so It absolutely is. Like, for example, diabetes. Let's take a case there. I've had patients who've had pancreatic transplants, and all of a sudden their new pancreas is producing insulin. Their diabetes is effectively gone, and their eye disease has stayed under great control. I've had patients with diabetes who undergo significant weight loss, really reduce their need for any systemic therapy to control diabetes, and as a result, I've seen their eye conditions melt away too. But even in macular degeneration, even in diabetes where nothing else is done systemically, there are certainly cases where we can achieve long-term suppression. Um, and so I used to have a goal of trying to always get patients off therapy. Sadly, it can recur. So, wet AMD, my goal was to try to get people off. Once I got them out to 12, 14, 16 weeks between injections, we'd attempt to stop. And I still offer that to patients. But there is a risk when you stop that it could come back. So imagine a scenario where one eye is already lost and we only have the one remaining eye. We may really want to continue to treat that eye for very long term to really, really minimize the chance it ever comes back. Whereas another case where one eye is perfect, 20/20, has no wet macular degeneration, the other eye has been receiving therapy for a few years, it still has good vision, but it's lower than this eye, then we might really consider in that case stopping the therapy to ease the treatment burden. And for sure, I've seen people stay their medication, their underlying disease suppressed for many years after stopping therapy. So it's possible in many of these conditions, retinal vein occlusions where we inject for a long time, it's possible people can form what's called a collateral vessel that sort of shunts past the area of blockage and can produce long-term stability within the eye. So it's definitely possible, but we know from many studies that that if we undertreat patients, we often do them a disservice. So we want to really make sure that the disease is totally suppressed and stable before we would consider stopping therapy.
And I think that just highlights the importance of seeing your eye doctor regularly, right? Going for those exams and making sure that things remain stable.
Stable and getting the little pictures that really tell us a lot about what's going on.
Yeah. Okay, so Claire's asking, are there any complications if a person with AMD needs cataract surgery?
That's an excellent question. And so it is safe to inject before, I say before, during, and after cataract surgery. So if someone has cataract surgery, I'm probably going to wait a week before I dose them their next intravitreal therapy to let the wounds of cataract surgery heal. If a patient has cataract surgery coming up and say I give them a dose of the therapy and then next week they have cataract surgery, during the cataract surgery, there's a lot of fluid that flows through the eye and it may wash out some of the medicine that I put in. So I might want to treat them a little bit earlier after their surgery, shorten the interval just a bit because of that stress of the surgery inside the eye. The real controversy, though, is does taking the human lens out of the eye and replacing it with a new artificial lens, does that change how light comes into our eye? And might that increase or potentially decrease our risk for macular degeneration getting worse? It's an area of controversy. Certainly the lens manufacturers have been thinking about it. They produce lenses that try to block some of the harmful rays of light that come into our eyes. These are also filtered out by our own natural lens, by the way. So they're trying to mimic that so that we don't overexpose the retina to some harmful rays of light after cataract surgery and potentially allow macular degeneration to progress.
Thank you. And then we have another question here from Clara. So Clara is asking, is it common to experience sharp pain in the eye for several hours following an injection?
Yeah. So usual cause of that, the most common cause of that is the antiseptic that we put on the eye. So as we know, like I scrub my hands in surgery with antiseptics before I go into surgery, and I get little cracks and breaks in the tips of my fingers, and they can be very painful. And I treat it by putting a lotion on my hand as much as I can. And so that irritation can happen on the surface of the eye. Again, usually the antiseptic going on and sort of drying out an area, irritating an area, putting little cracks in those surface cells. And so the best therapy to help with that is to lubricate the eye with an artificial tear drop. Similarly to the best thing I can do for my fingers that break down and crack and dry out when I scrub for surgery is put a lotion on them.
This is a great question from Nancy. We didn't mention at all dry macular degeneration. So Nancy's asking, is these medications used for people who have the dry form of AMD?
So that is an excellent question. It's a very timely question. So VEGF itself, no, doesn't play a role really in dry macular degeneration. There has, in fact, been some suggestion that chronic VEGF suppression can cause dry macular degeneration lesions to grow a little bit more. So that's been suggested, again, controversial. And I always remind patients that suppressing wet macular degeneration is the most important thing. So don't think or don't worry about these injections advancing your dry macular degeneration. In fact, by drying out your retina, you probably allow us to see the underlying dry degeneration more. And now we can appreciate that with time that worsens. So right now, the best thing is continue to get your injections, take your vitamin therapy for dry macular degeneration, but anti-VEGF therapy in and of itself doesn't treat dry macular degeneration. However, there's a new class of medications coming out, complement suppressors, that are also given by injection inside the eye. And these have been shown to slow the rate of dry macular degeneration or geographic atrophy progressing. So they're to slow the rate. So we're very early in our dry macular degeneration injection therapy. And the reason I say that, it's like, remember how I started this talk about our therapy for wet macular degeneration? I said at the start, we could control it. We slowed down how quickly you lost vision, but we didn't restore the vision. That's where we're at now with our dry AMD therapy. We're now starting to have drugs that can slow it down, but we don't have drugs that reverse the dry changes and make it better. We just slow down the rate of production. So we're very early in injection therapy for dry macular degeneration. But like anything, things are going to improve and get better, and those companies are going to continue to work on this. And those injections have some side effects as well, including potentially the chance that they could worsen wet macular degeneration. So you see, with all drugs are side effects. So there's some discussion of combining the two together, so you fight dry and wet at the same time. But again, those discussions are very early in the process of producing safe, effective, and healthy therapies.
And those injections for dry AMD, they are not yet available in Canada. Is that correct?
Correct. So we're getting to that point where they're going to be approved, and then we have to come up with a system of supply, and so the companies are working towards that. So they're definitely available now in the United States, and of course, bigger markets, so things start there. But they're going to get favorable approval here, and then we just have to work out pricing, supply, who's going to pay for them, provincial funding, and the supply chain within Canada.
Thank you. So Terry has a question. When I get injected, if the eye pressure is not reduced immediately, my cornea gets overpressurized and goes opaque for a few hours. How common is this condition?
Yeah, so think about any closed sphere that when you inject more fluid into it, the pressure goes up. So it happens to every single person. Every person we inject, pressure goes up a little bit. Now, sometimes a little bit, not of the injection. When we inject into the eye, the medicine goes rushing across to the other side of the eye. Sometimes we'll see a little dollop of fluid. Now, this is vitreal fluid, doesn't have any medicine in it, come out at the point of injection, which is almost a good thing because that lowers the pressure inside the eye. So most people, after they get the injection in their eye, the pressure goes up a little bit. But most eyes, that is not even noticeable to the patient, okay? So the patient doesn't experience blurry vision. The patient doesn't experience pain or headache. But some eyes are more susceptible to more exaggerated and sustained pressure rise from the injection inside the eye. So just the anatomy of those eyes. Often they're eyes who have glaucoma or underlying issues with pressure control in their eye to begin with, but they're not always. They can be just anybody, and they get this response. We inject the same volume into two different eyes. So you learn that each eye responds to the medicine differently. Each eye's pressure may respond differently. So some eyes, the pressure goes up. Typically, when the pressure goes up, it's like squeezing a little bit on the optic nerve, and the eye goes numb a little bit. And so it's like the signals aren't going through the nerve, so the vision goes down. Typically, people will have a headache around the eye, okay? And those are signs that the pressure goes up. So we check the vision right away afterwards, and the vision is really reduced. They can barely see light. Well, we need to lower the pressure in those patients. So often that can be done with drops, or very rarely, you will need to withdraw a little bit of fluid intentionally. So this is not something that needs to be done in most eyes, by all means, not in all eyes for sure, but in some eyes there may be a role for reducing the pressure. You inject the medicine in, and then I actually take the fluid off when I have to from a different part of the eye. So the medicine goes into the vitreous at the back, and I take off a little bit of aqueous fluid at the front to normalize the pressure. But high pressure in the eye, we talked about how it can cause pain, how it can cause headache, how it can squeeze the nerve, reduce the vision significantly. And it's true that it can also, in some cases, so much pressure push some extra fluid into the cornea and give the cornea a bit of swelling.
We have another question here from Helene. She said, is the risk of using a multi-dose vial significantly higher than a unidose syringe? So talking, I guess, about Avastin, particularly how you're talking about it's dosed out. Is there a higher risk of infection, I guess, when you're doing that?
Yeah, great question. So I do believe that the risk is lower. When we get the syringe directly from the manufacturer with the medication in it, all ready to go, there's no handling of it, right? Like when we get a vial, we have to break the top off of it. It's exposed to the room air here, whereas those syringes are prepared in like a very, very sterile environments where all impurities are pumped out of the manufacturing facility, whereas we're often doing it just in our clinic right here. So what impurities or anything are in the air? We swab down the top, we set it down, but then we have to open up another needle. We have to put a syringe on it a needle on it to draw up that syringe, to draw up the medication. Then we have to take off the needle that we drew it up with. We have to put another needle on it, and then we have to take it over, give it to that. So every step, I think, induces a tiny bit of risk. Now, what's done right now with Avastin is it's often prepared in a very specialized facility as well. So under a sterile fume head, everybody's masked, gowned, very sterile, and they'll draw it up into a whole list of 40 syringes, let's say. Then those syringes are capped and shipped to us. But again, now it becomes several steps, right? Somebody else has to, what we call, compound the medicine. Then that medicine is shipped to us, maybe shipped to us in syringe types that it was never meant to be stored in. We don't know how long it's sterile in there. Whereas the ones that come directly from the manufacturer are extensively and rigorously tested so that they know that the medicine is stable and stays sterile and inert in those containers. Plus, it's quicker. Let's be honest. If I have a patient come in, I put the speculum in, I inject, and the pre-filled needle, the whole procedure is quicker. Whereas if you're doing it the other way from a vial, there's more steps involved. It takes longer. Patients wait longer in clinic.
We have a question from David who says that they have been using Eylea for a number of years and their ophthalmologist has told them that their AMD is stable. And he's saying, can I expect that this will remain stable forever or will there be deterioration eventually?
Yeah, so again, the Eylea controls the wet component of macular degeneration, and indeed you can be stable for years. Unfortunately, we still have the dry component that could progress. So many people also take vitamins right now as the best therapy to reduce that. But yes, you could stay stable for many years, but it's never like nobody has a crystal ball to really predict how one patient will do. Will they get underlying geographic atrophy, or will, at some point at a 4-month extension or something, the condition starts to recur. And so again, it testifies to the importance of making your appointments and getting the imaging and just assuring that there's not something brewing under there.
You just mentioned vitamins, and there's a question here from Clara about how do you determine which type of vitamin supplement formulation is the best for each individual? Are there genetic tests like macular risk? Are they recommended to determine, for example, if the supplements containing certain things like zinc are not advisable?
Yeah, so far, none of the large ophthalmology societies, the American Association, the Canadian Association, the European Association, none of them have seen value in those genetic subtypes. This is the thing. So We have several large studies from the National Institute of Health conducted in huge numbers of people that look to see if the AREDS and AREDS2 formulation, vitamin C, you got vitamin E, you got beta carotene, you've got well, beta carotene is now replaced, of course, with lutein and zeaxanthin, and you got your zinc, and you have your other components of it. So those are well studied. And I got to be honest, a lot of us poo-pooed it at the time. We didn't think vitamins would have any role to play. Turns out it did slow the risk of production. Now, the problem is many of the data that is used to infer that one group may do better or worse with a different type of supplement is gained by subdividing the data into smaller groups. And I always worry that you'll get a spurious outcome. If you subdivide data enough, you may find that people born on a Saturday shouldn't have zinc, and it's just a random fluke because the study was not designed to determine who shouldn't have zinc. And so when you start to subdivide into smaller and smaller groups, you can find a suggestion that may not truly reflect the best care for the patient. So until we have larger studies that really show that there is an advantage or disadvantage within certain subtypes, this is not something that I am a proponent of. Let me be absolutely clear there. And that view, I trust in the recommendations that come from the overall governing societies that look at this in an impartial way and have come up with that recommendation. So I'm not pushing those types of tests. And I think the best evidence we have is the large studies from the United States that came up with the AREDS and AREDS2 formulations as a way for people to reduce their risk the best they can. Certainly there's enough different manufacturers now that it's really driven the cost down. So these should be affordable. And even people can buy the supplements on an individual basis from health food stores if they can't tolerate one of the components of that formulation.
Absolutely. Okay, we are getting near the end here, and I see there's so many questions, which is great. I'm going to try to combine a few of them here just so we can maximize our time. So I have several questions that people have asked about, things we've talked about around sort of the intervals between injections and not knowing, how many injections they're going to get and if different medications are going to be different. And for example, we had a question here from Murray who was talking about, his injection time has increased but he still feels like his eyes are slowly deteriorating, but it's hard to quantify, So I guess the question would be, is there things that people can do between those appointments if they're worried that something is not quite right? What should people do?
Yeah, and Murray makes a great point there where, we have a control but not a cure. We can suppress fluid, we can suppress hemorrhage, but sometimes those cells continue to undergo apoptosis or atrophy. So I make the analogy, it's like we can style the hair really, really well, but sometimes our hair still thins with time. And so there is aging change that goes on inside our eye, which some of it's normal. Our body, as we age and develop, our muscles may not be as strong, our joints may not be as limber. And so some of the cells inside the eye do degenerate with time. And so there's that in the background. And so we try to be as objective as possible. And that's why, looking at something like the OCT, it really will pick up any fluid or hemorrhage that's present. And there are home monitoring OCTs and things like that. There's AMSR grids, which people can use at home. I don't push for home monitoring OCTs. I mentioned it, but I think that's still something in the future. But, an AMSR grid or things like that to see if there truly is added distortion coming into your vision. I tell people it's very simple. Like I look at a door in my office here, and it's got the pattern of the door frame, and you can look at that with one eye and with the other eye and just see, okay, is there a new distortion or bend or waviness that's definitely getting worse? Then you have to come in. But sadly, people are still sometimes we suppress the disease totally, but we don't keep them perfect because of some of those concurrent aging changes that are happening.
Yes, and I always encourage people we have AMSR grids at FBC that we send out for free. So if you'd like one of those grids, you can always email us at education@fightingblindness.ca. We're happy to send you out one. It's a great thing. People put them on their fridge, just have it handy. You can always have a quick check. Let's see. Okay, let's do one more question. So we had a question here. I was diagnosed with this is going to be a mouthful. Polypoidal
Choroidal
choroidal
vasculopathy.
neovascularization.
Polypoidal choroidal vasculopathy. We can consider that it's in the same disease spectrum as AMD. It has a genetic predisposition in common and some other people from other parts of the world. But yes, please continue.
So they've been diagnosed with that disease that I won't butcher again 20 years ago in his left eye, treated with injections and various anti-VEGF treatments, and has been told that the eye condition is stable. And they said they're 71 years old, don't drink or smoke, blood pressure is normal, but is there anything they can do to prevent their condition from becoming bilateral?
Yeah, so polypoidal choroidal vasculopathy, we don't know quite as much about it as we do AMD, so we're not sure if the AREDS type vitamins would apply. But the only thing I can tell people is the things that you were told in your youth from your grandmother that keep you young and healthy, they're universally true. And so, maintaining a healthy body weight, maintaining physical activity, staying physically active, eating lots of fresh fruits and vegetables, healthy diet, those kinds of things control aging in a lot of factors, so high fat diet, smoking, high blood pressure, we know that ages you in many ways. And so the best advice we really have is things that you've been told that keep you young and healthy, they do try to prevent this type of age-related change, like the polypoidal spreading from one eye to the other. And as one doctor put it to me, because all of us could eat better and be more active, and I'm certainly one that could. They said, if something tastes super yummy and goes down super easy, it may not be the best thing for you to eat. The apple or the carrot may be better. And I think that's a truth, not only to help with your eyes, but to prevent many age-related diseases, heart disease, diabetes, a lot of conditions.
Okay, so I think we're going to have to end there, just being mindful of time. I apologize that we didn't get to your question, but we do have always our health information line. So you can email us at healthinfo@fightingblindness.ca, and we can help find you resources and answers to your questions if we were not able to get to your question today. Thanks again, Dr. Hurley. It's been great chatting with you. Dr. Hurley always has the best analogies for things. He explains things so well. I love the rose and the Lego. They're great explanations for these more complicated concepts. So I appreciate that. Thank you.
Awesome. Well, it's always a pleasure. Thank you so much for having me.
Thank you.